Yeah, good evening, everybody. Welcome, students. I think last week we shared on this Monday, actually, we shared resources on developmentally supportive care and one of the parts of thermoregulation, which is kangaroo mother care. I hope you have gone through the resources. Today we have the course convener Sushma ma'am also with us, and the faculty is Dr. Ranu Sachdeva from AIMS New Delhi. Ma'am is additional professor there. And please ask your colleagues to join fast, and we shall be beginning. We welcome Anu ma'am. Anu ma'am, we can start. You need to unmute ma'am. I think Rituparna, ma'am is muted. So, and
Yeah,
co-host also. Please make ma'am co-host.
yeah. So good evening, everyone, and it is my pleasure to uh, be with you all. And first of all, I would like to thank Ma'am Professor Sushma Nangia. She has been my teacher, and obviously the current NNF president. Thank you so much, ma'am, for giving me the opportunity. Many thanks, Pratima, for just helping me with the draft, what is expected for me to present today and for our MD residents in pediatrics. So what I'll do over the next 35 minutes is that I'll list out what is a must know thing for on kangaroo mother care and developmentally supportive care, which an MD resident or a postgraduate student should know. And we'll have a small question at the end on which you can reflect, we can discuss, and then I'll be open for questions, queries, anything that you would like to ask me, anything that you are not able to understand. So please be frank, and we can discuss the queries that you have towards the end of the session. Request everybody to remain muted, and we will actually give you time to interact towards the end of the session. Thank you so much once again, Team NNF. And Pratima, I want you to confirm whether my slides are visible and I'm audible.
Yes, ma'am, you are audible. The slides are full screen and they are visible.
Thank you
Yeah.
so much. So we are into week 4 and we will talk about developmentally supportive care first. So I want to understand before I begin, and I want your hands to be raised. How many of you are trying to practice or have heard the word developmentally supportive care before we actually opened the current week of NNF for developmentally supportive care? So I would request all of you to raise your hands who have heard about developmentally supportive care before joining this webinar today. So let us see how many hands are up. I hope all of you know how to raise your hands. There is an icon coming below, and you can express your emotions. And okay, so we have Pragya, we have Deepika, we have Ashish. Oh, I'm happy. The list is going long, long, and long. So we have so name yourself when you enter Zoom so that we can call out to you. We can address you by names. Wonderful. So almost 15 to 17 of you know. So thank you, Arun, for raising your hand. Again, we see Vandana Pandey, Amber Sharma, Akanksha Mishra, Ashish Kumar. So many of you have heard this word. So this is something which is not out of the blue. This has come up. So way back, if you remember, this was Florence Nightingale in the 19th century, and she said that healing environment, something which is comfortable to any person admitted in the hospital, that can actually improve the outcome of the baby. And therein the concept started that we are intensivists, we are neonatologists, we address ourselves as the people who would actually be able to take care of a neonate as small as 450 grams, but then we will never be able to replicate what the baby desires to be. And the best environment for the baby is actually the mother's in utero environment. So developmental supportive care, as we go from here, is a set of practices, something which you need to do and something which you don't need to do. But the idea is that we wish to create beneficial environment or beneficial strategies to the sick preterm neonates to cope up with the adverse environment in the NICU. Remember, every alarm, every prick, you're speaking by the baby's side, you're touching the baby unnecessarily, you're lifting the baby, you're pricking the baby, everything is actually causing pain or harm to the sick preterm newborn. And the logic that we work with is that our strategy should actually be do no harm. So with that background, let us look at the domains of developmentally supportive care. So you need not mug them up. These are not for remembering ad verbatim, but just try to relate, just try to think. So I, as a pediatrician bedside taking care of the neonate, I can request you to put your hands down now, please. So these are the 7 essential components of developmentally supportive care. Let us see what they are all about. So, 1, we need to safeguard the sleep. Second, we need to minimize any kind of pain, any kind of stress to my newborn baby. I need to optimize nutrition. I need to partner with families to show them mutual respect, to talk to them, to communicate with them, because it is their baby. They have entitled us with the so-called power that, you can take care of my baby. I need to create a healing environment. There is a way to handle these babies. And finally, last but not the least, I need to protect the skin of the baby. So these 7 things are wonderfully depicted in the next slide, which is here. So why is this so, and why do you actually see these 7 things coming in? So when I do these 7 things, what happens is that we, 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 we somehow, even though we are the so-called intensivists, we somehow fail to remember on most occasions that newborns can smell, newborns can hear, newborns can appreciate your touch, newborns are very sensitive to temperature, and they are also very sensitive to the environment or the ambient light. So these small bits and pieces, these small efforts from our side can actually go a long way in improving the overall outcome of a preterm newborns. And we, what more than having a developmentally normal child when the baby walks in with the parents with the hand held to your follow-up clinic. So what we'll do is we'll talk about these 7 steps one by one. So the first one is to safeguard sleep. So how do I promote sleep in my newborn? I give the baby a boundary by the side. I tuck the baby properly so that the baby is in a well-flexed posture. At the same time, I promote skin-to-skin contact because this is what is ideal for the baby. This is what the baby always deserves. So when I say consistent contact, the other side of the coin is kangaroo mother care. We'll talk about how are they different and how does kangaroo mother care work and what is the benefits in the subsequent slides. So sleep can also be ensured by not talking bedside, minimizing sound, minimizing discussion with your fellow colleagues, with your faculty, with your seniors. Do not lend a deaf ear to the alarms. Set your alarm limits in such a way that each alarm that rings actually worries you that why is the alarm ringing? So don't go and immediately mute the alarm. There would be a logical reason why the alarm is blowing. So change the alarm settings in such a way and do not lend a deaf ear to the alarm. Ensure that a day-night pattern is established. So I don't want my babies, they also deserve a diurnal pattern. They also deserve to sleep in the night. Keep the environment as quiet as possible. Keep the ambient light as minimum as possible. And when you have to do procedures, obviously, you cannot compromise the visual field, but then all the other times be very sensitive and promote sleep and do not drag the chairs inside the NICU, rather lift them up and take it to the other side whenever required. So having talked about safeguarding sleep, the next important step is how do I minimize pain? First thing is cluster care. That means I would actually club all the activities together. And when I say clubbing all the activities, it means that the IV prick should be clubbed with changing the diaper, should be possibly done after feeding if the baby is on full feeds. Remove the adhesive only with a wet wipe so that it has become loosened on the skin surface. Don't immediately pull it away. Tell the parents that this baby perceives pain, has a threshold towards pain, and have a unit protocol to document and manage pain and stress and give both pharmacological and non-pharmacological measures to prevent pain. Do not give unnecessary touching and avoid any painful or stressful procedure. The third thing is optimal nutrition. So the first take home from today's session should be that breast milk is the only feeding recommended for a term newborn. And my teachers would always say that if the patient asks you, can we give cow milk feeding to the baby? The immediate answer should be, and that is what I speak even today, is that the cow milk is actually meant for the cow's baby. So how can you give cow milk to your baby? Have faith, the mother, by God's grace, mother does produce enough milk for every newborn baby. So your role is to prevent worry, stress, pain, doubt. The mother can produce the milk which is required for her singleton or or twins or triplet newborns. Provide optimal support for the mother, give her enough amount. They tell the family to ensure that she takes a good diet. The other thing which is helpful for preterm babies is non-nutritive sucking. And mothers must be encouraged to participate in all the daily activities of the baby so that you promote her breast milk production. The fourth important thing is that the family is our partner. Show them respect, engage with them, ensure that they are satisfied with the care. For most parents, the strata which we care for in India, NICU is actually an alien environment. They are scared. They are very uh, thoughtful of what is going to happen to their small babies. The way they can actually participate in care and you can actually train them is training them in hand washing, telling them the importance of infection prevention, telling them the proper protocol for entry into the nursery, promoting developmentally supportive care activities, kangaroo mother care, and prepare them for discharge. So the fifth point is healing environment. This goes almost closely with protected sleep. We've talked about everything, but two important changes here is the physical environment and the sensory environment. So physical environment we talked about, like minimize sound, minimize light, ensure a temperature, ensure air changes. They would also play a role in protected sleep. Now, maintain a very healthy sensory environment, avoid unnecessary stimulus, unnecessary talking, adhere to infection control protocols, do not keep on pricking the baby unnecessarily, and have a healthy communication between caregivers and parents. So when I talk about position and handling, which is the other integral component, the sixth component, so what is the important thing? I mean, I can go and touch a newborn, I can prick the newborn, I can sample the newborn. What's the big deal in position and handling? So the big thing in this is that there is a paradigm shift now. Now the care should actually not be task oriented. Meaning Dr. Anu has to go and prick the baby. So she'll decide 10 o'clock, I'm going to prick the baby and I'm going to take the sample. It should be infant responsive care. If the infant is sleeping and it's an elective investigation, try to postpone the investigation till the, if it is not relevant, better you don't do that investigation. If you're not going to interpret it, that's the result is going to lie in the lab. You're not going to even bothered about what the result is. Do not do the sampling. Why is the sampling required in that case? However, in case the sampling is imperative, obviously it has to be done with proper pain care procedures. If the sampling is elective, so you can sample maybe 2 hours later or 3 hours later, club it with the time when the infant is actually awake. Cluster the care. Do not go and touch the infant and unnecessarily keep on handling. It should be an activity dependent development. You observe the baby during the day, what kind of activities the baby is doing, and ensure that you give a good nesting. Nesting is the boundary that you create around the baby, and it is there to mimic the classical in utero environments. If you know, the uterus is also something like a nest which you create around the boundary of the baby. That is the logic of creating nesting. Finally, how do we protect the skin? Skin is actually the, if you ask me personally, it is the organ which, if taken care of, can prevent majority of the infections occurring in this neonate. So it plays a role in thermoregulation. It plays a role in fluid balance. It is an information conduit for the brain. So it carries all your signals, your touch signals, your pain signals. It goes and carries to the brain. Why is the preterm predisposed? Because the stratum corneum is very thin. So there are a lot of transepidermal water losses. So what do? You use some hydrogel-based adhesives. Do not touch and handle the newborn frequently. Use evidence-based guidelines and always do gentle care in the neonate. So just summarizing, developmental supportive care is a continuous process. It improves growth, it reduces stress, not only to the mother, but also to the newborn, and it provides the much needed stimulation to the developing brain. So that brings me to the closure on developmental supportive care. So I would actually go on to KMC and we can take the questions in the end. But in case you would like to ask some questions, I would have some hands raised for on developmental supportive care. So before we begin KMC, I would like to stress upon 2 or 3 important things about developmental supportive care. You do not require an additional setup. You do not require additional hands. You don't require additional nurses or additional residents to implement this. The only single thing that can help you implement this is partner with families, do family supportive, interact with the families, give them respect, engage them in the care of the babies, Train your nurses. It is a simple yet dynamic and ongoing intervention which is bound to give you huge dividends, and the baby's developmental supportive care is bound to improve the subsequent neurological issues you may frequently encounter when you do not give developmentally supportive care. Now, kangaroo mother care, the classical two things which an MD postgraduate would tell me is, ma'am, it is skin to skin contact and exclusive breastfeeding. So, we would love to tell you that kangaroo mother care actually has four important components. So, you give skin to skin contact, you give exclusive breastfeeding, but please remember that early discharge and follow up is also an integral component of kangaroo mother care. Frequently, the reason that these two components, the last two components, are uh, many times disregarded is because there are issues with follow up, there are issues with promoting early discharge, but then the kangaroo mother care actually has four integral components, and this has to be imbibed in all MD postgraduate students in pediatrics. So, whom to give KMC? So, the cutoff is 2000. You might hear a cutoff of 1800, which is fine. But then babies less than 2000 grams, as per the KMC India guidelines, should be a high priority for kangaroo mother care. So, when do we start KMC? There are different cutoffs. So, babies who are less than 1200 grams, and we have Dr. Pratima sitting here. So, these babies actually should be given kangaroo mother care the moment they are stable. For the babies in between the weight of 1200 to 1800 grams, these babies should also be started on kangaroo mother care as early as possible. And if they are more than 1800 grams, you actually can start the kangaroo mother care or skin to skin contact directly in the labor room. So, at your level, what you need to understand is ensure that minimum level of stability. When I say stability, I do not mean it is actually getting no oxygen. I also do not mean that the baby is getting IV fluid, so the baby is not stable. Babies who are on minimal CPAP, non-invasive support, babies who are on minimal IV fluids, babies who are on orogastric feeding, babies who are on oxygen are and they are stable, they should be started on kangaroo mother care as early as possible. So who can provide? Ideally the mother, this you all know, but you can see the picture, the grandmother, the father, everybody is participating in kangaroo mother care. We prefer that the same person continues. One, because of logistic reasons. Two, we don't want many people coming into the NICU. So one person is identified in addition to the mother who can continue to give kangaroo mother care. So why do we advise KMC? Why should the MD postgraduates think that, we should give KMC? What is the big deal? We have incubators, we have warmers to take care of our small babies. Why kangaroo mother care? So there are advantages to the baby, to the mother, to the family, to the community. So what about the baby? So KMC decreases or improves temperature control, decreases the risk of apnea, decreases oxygen requirement, decreases pain, improves hospital stay, increases weight gain, increases overall physiological stability, overall health and well-being. So, I mean, such a bountiful thing, and why should we not doing kangaroo mother care for our babies who are eligible for this? So, logically speaking, and that is why I kept this second paragraph in red, because it is actually a normal biology. So we are trying to mimic a space for the baby, which is the closest space which can mimic the neutral environment. The baby feels the mother's warmth to touch, listens to her voice and heartbeat, so hearing, sucks the breast milk, so taste, and has eye contact with the mother and smells her odor. So it satisfies all the five senses of the newborn infant. For the mother, improved breast milk production, increased rate and duration of exclusive breastfeeding, decreasing mother's stress, empowering them, stronger bonding, mother's confidence, and deep satisfaction to the baby once she's involved in active care of the newborn baby. What about the family? I mean, if the mother is doing KMC, it is giving benefit to the baby and the mother. KMC saves money. The baby is discharged early, father can resume duty early, babies have a higher intelligence quotient, it decreases child use and abandonment. So, such a wonderful thing and so close to our hearts, mimics the in utero environment. Please go ahead and propagate kangaroo mother care in your respective units. Community, it reduces healthcare costs, baby get home early, less artificial feeds, less antibiotics, less equipment requirement, and improved duration of hospital stay. So KMC uh, is wholesome food for the baby. So please go ahead and promote kangaroo mother care. So people have tried to classify KMC as short KMC, extended KMC, and long KMC. Do not really worry about the hours. But what you should remember from this slide is that each KMC session should be at least 1 hour. Why so? You're taking out the baby from the care area, you're giving the baby to the mother. Again, you're displacing the baby and placing the baby back. So at least when parents come and tell them that you should be doing KMC for at least 1 hour, and you count the duration of hours as cumulative over 24 hours. So you are in your unit doesn't practice KMC. So how do you tell the mother that what is that she should be done? Go to the mother. The first thing is G. So greet the parent, ask her how she is doing, any issues that she has. So the first word is something that we request you to remember. So it is G alpap. So I speak it G, greet the parent, ask her how she's doing, listen to all her queries. Please understand, as an intensivist, you also need to be an active listener. You cannot speak, keep on propagating, and then not lending a listening ear. Parents are huge information givers. They will tell you something which others may never be able to tell you. Listen to the mother's query and then counsel her. So you tell her how to do it, how long she should do it, what does she need to wear, does she need to take a bath every time? Finally, do not forget praising her for whatever small things. We often end up, as doctors, we would end up ridiculing. तुमसे ये भी नहीं होता है. Why didn't you not do this? You should have at least come for 4 hours. Imagine mother has delivered. She's in pain. She requires your support. So praise her involvement. Confirm her willingness for KMC. And then finally, before closing the discussion, confirm that she has understood what you wanted to teach her. So what do we require? Do we require a separate ward? Do we require 10 nurses? Do we require separate clothing? The answer is no to all my questions. So it's just a small effort from you sitting in the audience, from the nurse practitioners working with the babies. Train the nurses, train the doctors and physicians involved in care of the baby. Preferably, you should have videos in local language. In case you don't have, they are available with NNF. They are available on the AIMS website also. You require a reclining chair for prolonged KMC. For example, if the mother would be sitting erect for about 2 hours, she might just get tired. So you require some reclining chairs. No extra clothing. This mother needs to wear a front open gown. The baby has to wear a cap, a diaper, and socks and mittens, and a front open clothing, or what we call as jhabla. So this you can see on my left is the classical position in which the mother needs to hold the baby. So the mother can see the face of the baby. The baby is actually in slight sniffing position. They are in eye-to-eye contact. The nose and the mouth of the baby are not covered. The neck is in line with the body. Mother is supporting the baby well with both the hands. The baby is in frog-leg position, chest to chest. Legs are flexed, arms are flexed. Mother is supporting the bottom. And then the mother-baby diet is covered with a layer of blankets, but both are watched if the mother ends up sleeping. Some relatives should be monitoring the baby while in KMC if the mother goes off to sleep. Otherwise, mother is the best monitor. So what is the monitoring that we talked about? Monitoring. So if you start it immediately after birth, please check the baby once you started the KMC every 15 minutes for the first 2 hours. So look for activity, look for breathing, look for color, and look for temperature. You can use touch method also to check the temperature of the baby, monitor the position of the neck of the baby. See the activity if it is normal or abnormal. See the breathing, see the color, see the temperature, and the position of the neck also needs to be monitored. So when do I discharge? So these criteria are relative. Check if the infant is able to maintain the temperature. You continue, mother is confident in giving feeding to the baby by a pallet day. This cutoff of weight gain, 15 to 20 grams per kg per day, is the standard cutoff that we use for feeding in all our preterm babies. The baby should not be having any acute problems. Mother should be confident. The baby should preferably be above 34 weeks. Weight should be more than 1400 grams, and mother should be doing prolonged KMC for at least 3 previous consecutive days, and baby should be gaining adequate weight. So these are the pre-discharge criteria, which as a postgraduate resident, you should know that, if these are obeyed, then I will consult the mother and take a decision for discharging. Mother continues to provide kangaroo mother care at home. We see a wonderful picture of a mother who's actually hanging the clothes out in the sun, and the baby is in kangaroo mother care. We can use binders. So there are commercial binders which are available, but you can make binders from a homemade dupatta, which can support the baby. So developmental supportive care, we summarized initially. So KMC improves survival. It improves breastfeeding. It's a very good option for decreasing mortality, improving exclusive breastfeeding. Do KMC and recommend KMC even at home. So can there be some barriers? We talked about all the positives for KMC till now. So at the facility, it might be that the mother is not eligible. She is sick. She has resistance from the family to participate. She's actually worried that the baby might get infection. Baby has long lines. So the other thing is that I might be a person who would think, no, we don't require KMC. The lines may come out. What will the mother do extra? So please stop KMC. So mothers might be in guilt. The staff might not have the knowledge to do KMC. So what is your role? Your role is to ensure that these problems are taken care of, and the staff or you yourself are gradually improving in the thought process that yes, kangaroo mother care is important. What about the community? There are some communities which might give a reason. There are no binders. We don't have water for bathing. There is no training. There is a lot of workload. Mothers have to go out for work. Please try and work out a method in which the KMC at the community level and the home can also be supported. Now, this brings us to the end of kangaroo mother care discussion and developmental supportive care. So let us see a case scenario. It is a 34-weeker and 2.1 kg. So it's a good weight baby. Now on day 3, the baby loses weight. The baby is 1.8 kg. Mother has engorged breast, but she doesn't want to express milk and doesn't want to do KMC. The grandmother says that, mother is not producing enough milk and mother is having unnecessary breast engorgement. You give me discharge immediately, and I would start the baby on cow's milk. So my question to the students who are here is, number one, I'll give you options and then you can raise your hands. So who would wish to start this baby on KMC? And the floor is open. We have 85 of you. It's a 2.1 kg baby who actually becomes 1.8 kg. We understood from one slide the PowerPoint. And I would now put the question to you, who would like to express tell the mother that kangaroo mother care is important and should be given. So Puneet says start KMC. Kuldeep has raised his hand. I don't see any other resident raising the hand. So you don't want to give kangaroo mother care to a 1.8 kg baby now? Okay. Geeta has also raised her hand. She wants to give. Wow. So my voice actually led to many people raising hands. So Shivani, Arun all have raised hands. And okay, so that means out of 86, 4 of you want to give kangaroo mother care. The other 82 do not want to give kangaroo mother care. I see more hands being raised. So I'm happy. So now the question and the answer to which has to be put in the chat box is, it is only for those who do not wish to start KMC. What is the reason why you do not want to start KMC? What is stopping you from starting KMC? Okay, Neha says, I need to start. No, Neha, I need the answer from those who said it is not right, or 80, almost 80 of them said, did not agree that we would start kangaroo mother care. So now I see more hands raised. Okay, so can I request, okay, let me see who has not agreed for KMC. So I want Akanksha Mishra and Akanksha Lal, either of the Akanksha's, to unmute themselves and let me know, why do you not want to start kangaroo mother care in these babies? Are you scared? Or are you worried that somebody might catch you because it is not in the guidelines? Baby is 2.1 kg. So the take home from my question, which I said is, so Megha, why do you want to start KMC? Can you unmute and tell me? Or if you're not able to unmute, just put it up in the chat box. And this answer has to come from Megha or Pradeep or Fauzia. So either of you three, please put up in the chat box, why do you want to start KMC in this baby? Akanksha, engorged breasts in the mother. So KMC might improve letdown. She might feel much more confident. She might feel less stressed. And so the link, Akanksha, which I wanted was that KMC would decrease her stress and would improve her letdown. Her engorgement is likely to improve. Okay. So what is the other reason? Why do you want to give KMC? Pradeep and Apurva and Preeti, the floor is open for you. Okay, yes, Pradeep, I agree. KMC will actually increase the chance of explosive breastfeeding. So how do you manage such a mother or a grandmother who's very difficult to converse with? So the grandmother is the obstacle. She is there. She's saying that the breastfeeding is not a good option. I'm going to give cow's milk. So what will you tell her? What will you tell her? So you can just type in the chat box. Okay. So you will explain the advantages, exclusive breastfeeding, weight gain. Grandmother is still not convinced. Can I have some more advantages? Okay. Will it improve mother's bonding? Excellent, Neha. Better bonding and mother might feel. Excellent, Kuldeep. So advantages on survival, wonderful. So I wanted to hear these all. So when you go back, and if there is a mother with a mother-in-law or a grandmother who's actually a difficult person to converse with, the first thing you tell her is it decreases mortality. If you start doing it, the baby is likely to go home earlier. Excellent, Kuldeep. The child will be a smarter child, no doubt. Tell the mother that the cow's milk is for cow's baby. Pradeep, excellent. Tell about the family financial benefits. Tell about the community financial benefits. So you all are now going to be the messengers to for this difficult mother. So we found out a plan which is very different. This baby lost breast weight 300 grams, which is fine. Why do you need to worry about it? Support breastfeeding for kangaroo mother care. Promote kangaroo mother care and support breastfeeding, and you will be ensured to have adequacy of feeding. This is the last slide. So instead of thank you, I would like to wish all of you a happy developmental supportive care and a happy kangaroo mother care. Thank you so much. And this ends I end my presentation here, and I would be more than happy to take up any questions from the residents. Yes, Puneet, I'm so happy. Cow's milk is actually for the calf. It is not for the human baby. I'm so very happy to have all of you being so interactive. Pratima, I'm done for the day, and I'm open to questions. Pratima, are you there?
Hello.
Yes, Puneet is asking me, Puneet, non-nutritive sucking people have tried to use, and non-nutritive sucking is basically sucking on an empty breast. Some people have used non-nutritive sucking as sucking on the nipple, which is not usually recommended. There are chances of infection. But yes, it does promote the suck and puts the baby earlier to the breast. Kuldeep, the answer is yes and no. If you have good nursing care, so Kuldeep has asked me, ma'am, can a baby on ventilation be given KMC? So you would see babies in AIMS getting KMC on ventilator, but you need proper more vigilant monitoring with the pulse oximeter. If you do not have this vigilant monitoring, do not have a good nurse-patient ratio, I would dissuade you from trying it on ventilated babies. But Kuldeep, if you're working in a unit where all CPAP babies, all other state babies are getting KMC, this could be the way forward for your unit. I hope I'm able to answer your question, Kuldeep. Yes, Pavan. So the torch is in your hand. It's basically counseling of the mother and the family, which is going to be a huge game changer in promoting KMC. Okay, so ma'am has reaffirmed that when you can give good monitoring, the ventilated babies can be and should be provided kangaroo mother care. So Kuldeep, ma'am has answered the question, and I would second what ma'am has said, that if you have good monitoring in place, no doubt, go ahead and do KMC even in ventilated babies. Thank you so much, ma'am, for your input. So since I see no more questions, at what gestation, Pradeep, when the baby starts showing feeding cues, mouthing movements, sucking on the hand, licking on the orogastric tube, you should consider non-nutritive sucking. But don't get preoccupied with it. Use it as a big package with nesting, swaddling, other measures of developmental supportive care. So if there are no more questions, ma'am, do I have the permission to log out?
Yes, I was hoping that it will be more interactive. I saw that, yes, it was interactive. Students have been asking questions. So sure, if there are no more questions, yes, you may
Ma'am, if
log
you
out.
suggest, I can wait for a few minutes, but I see the participants logging out. That's why I asked, ma'am. I can wait, ma'am.
Yeah. So maybe we just see for 2-3 minutes, because yes, even I am seeing the numbers are dwindling
Yes, ma'am.
downwards.
Yes, Pradeep, it can be given with OG tube in place. Not an issue at all.
So I think if there are no more questions, so we would like to thank Anu for a very interactive and a very clearly messages which are very clear to the students, and I'm sure the MD students have understood. There's nothing which was a jargon or which were difficult terms which were difficult to understand. So thank you very much for conducting this session.
My pleasure,
Thank you,
ma'am.
Anu.
Thank you so much, ma'am. Ma'am, you're having a very bad throat.
Yeah.
Please take
Okay,
rest. Yeah, yeah. I'll wait, ma'am.
वो ना
If there are
ये
more
कोई जो
questions, I'll just
कोई है
wait
ना
on, ma'am.
कोई जो
okay.
गैस में जो पड़ा हुआ है वो जो निकालती है गैस वाला ना कमरे का ये स्प्रे में
Dr.
पर
Pavan, you
बहुत
may mute yourself. Your home talks are all audible to us.
हेलो
Yeah, Dr. Pavan, you're
हाँ
audible
डॉक्टर
to
पवन
everyone.
गर्ग दिस साइड I I am basically practice now. I'm to start my neonatology NICU within few days.
Right,
So I attend.
congratulations. Yeah.
I'm the new member. I'm the new member of NNF. But I am myself is 76 years old. But really, I want to regain my this neonatology. It's quite interesting. In our days, I was in rural area posted at Punjab. These topics were very important. These topics were really important somehow, comparatively. Now, the students and every neonatologist uh, definitely go for this type of congruent care, breastfeeding promotion, exclusive breastfeeding. They should all take interest in these type of. Right?
Surely,
Thank
Dr.
you.
Pavan. Thank you.
Thank you.
Yeah, so thank you, everyone. I think I will be logging out. We have about 40 members still. So those who want to ask questions can stay back. The others can log out, please. I'm waiting for you in case you're asking some more questions. Pragya, we did not intend to cover oromotor stimulation in this session. It is a contextual topic in itself. If you want some reading material, do type your email ID here. I would request and coordinate with NNF to send you specific reading material on this. But in this session, we did not want to cover oromotor stimulation. You can type in and send your email ID. I will ensure that we send you some reading material on oromotor stimulation. Thank you. Okay. Thank you, Pragya. But do read through the material, Pragya. I've noted down your email ID. Ma'am, I think I should log out now. Only about 30 students are left.
Yeah, if there are no more questions coming up, I think we can all log out. And thank you very much for conducting the session. And thank you all those who joined. Every Friday, we have this Zoom on the topic that is the week's topic. So do join in large numbers. Tell your colleagues and people who have registered for this course to join in. Thank you, Anu. Thank you.
Right,
And
ma'am.
bye-bye,
My pleasure.
everybody.
Thank you so much, ma'am.
Thank you. Bye.
Thank you.